Hello, my name is Kassim Javaid, and I'm very grateful for the organising committee for inviting me to share with you some difficult cases that you may be seeing in fracture liaison services. Here are my disclosures. So what I intend to do in the next half hour is to briefly summarise the structure of a fracture liaison service and then dive a bit deeper into two potential scenarios that may arise. The atypical femoral fracture, which we heard about already in the meeting, and also patients with chronic kidney disease stage 4 who may present with a fracture. So fracture liaison services are best summarised as specialist core services that deliver a pathway to identify patients aged 50 years and over with a fracture, perform a systematic risk assessment, and then recommend treatments that reduce the risk of fracture, which could include improving bone health and improving strength and balance to reduce falls risk, and then monitor those patients to make sure the recommendations are initiated and adhered to. And the way fracture liaison services work is to make sure that 80% of the patients are managed in a very smooth pathway. They don't have complicated comorbidities and their laboratory tests are normal. And it's for the really more complex patients that we will now be discussing what the next stage is. So let's start with this patient. She's an 80-year-old woman who had a history of prior radial fractures and was tried on risedronate, developed indigestion and switched to alendronate. She'd been on alendronate for around 10 years and then presented with a fracture on treatment of the femur. And when I saw her, we asked about the history of the femoral fracture, and she admitted to having 6 weeks of anterior thigh pain to the groin, and very importantly, the leg gave way after getting out of the shower, and then she fell. So many patients who come to a fracture liaison service will have had a fracture on treatment. And the management of these patients has really been influenced by this key document by the team at IOF, led by Adolfo Diaz-Perez, which summarised the definition of a fracture whilst on treatment that indicated the need to switch therapy. So they decided that having 2 fractures on treatment, or 1 fracture with either no reduction in bone turnover marker or a bone turnover marker that was above average, or a loss of spine density of more than 5% or 4% at the hip, indicated a fracture on treatment that was a treatment failure. And the recommendation there is to replace the treatment with a stronger anti-resorptive. If you're on an oral treatment, switch to an injectable, and if you're already on a strong anti-resorptive, then switch to an anabolic. And the reason for this is that we know that people who fracture on treatment actually have a very high risk of another fracture. This is some excellent work done by the team of Danny Preto Alhambra, which has looked across data sets, and here I'm just sharing the data from the UK, where they looked at patients with newly diagnosed osteoporosis, a newly diagnosed fracture, newly started on treatment, and then patients who've had a fracture whilst on anti-osteoporosis treatment. And they looked at the rates of a hip fracture, a spine fracture, a non-hip or non-spine fracture, or a major fracture. And you can see in the bars for the different cohorts, the highest risk is seen in those for fracture on treatment for hip fracture and for spine fracture. Incident non-hip, non-spine fracture was higher with those with an osteoporotic fracture, but fracture on treatment was also high, and it was also the highest risk group for a major osteoporotic fracture. So these epidemiological studies do show that having a fracture on treatment is actually a very strong risk factor for future fracture and an indication to increase the potency or strength of our medications. Now, the commonest mechanisms for fracture on treatment are usually related to incomplete adherence. This could be either cessation or stopping of therapy or taking treatment in an inappropriate way. Another less common cause is an undiagnosed secondary cause, and this is something that's been missed. But a really important cause not to miss is atypical fracture. So this is the X-ray of the femur, and here you can see some classical features. It's a subtrochanteric fracture. The lateral margin is horizontal, and there's a medial spur. So what's the next step for managing this patient in the fracture liaison service setting? Well, the key thing is to make the diagnosis, obviously manage the side that's broken, but also manage the other side and manage the risk of osteoporosis. So let's walk through those. So it's very clear, and we've already heard this, that there is a very structured definition for atypical fracture. It must be below the lesser trochanter and proximal to the subcondylar distal flare. There's a requirement for it to be associated with minimal no trauma. The fracture line originates laterally and is transverse, and that is a very important feature. And then if it does complete, there may be a medial spike. It's usually non-comminuted or minimally comminuted, and you may often get a beak or a flare at the fracture site. There are also some minor features. Importantly, at present, atypical femoral fractures exclude periprosthetic fractures, pathological fractures obviously, and fractures due to abnormal bone biology such as Paget's and fibrous dysplasia. How common are atypical fractures? Well, this is some very nice work from the team at San Francisco led by Dennis Black, which looked at the trial evidence to estimate the number of fractures avoided, both in terms of hip fracture in the blue line and all clinical fractures in the red line, compared to the expected numbers of atypical fractures associated. And in white women, after 3 years, you prevent around 75 hip fractures to every one atypical fracture. The risk is substantially higher in Asian women for reasons that are not yet quite clear, and we're not sure of the effect of family history of atypical femoral fracture on this risk. Don't forget there are other causes of an atypical femoral fracture apart from anti-osteoporosis medication, and they're listed here with some of the potential next step for investigation or assessment. Here's an example of Paget's disease of the bone with the very thickened cortex, and here you can see the atypical fracture with the very horizontal fracture line and a medial spur. Now, the management of fractures is actually very different to how we manage other femoral fractures. There have been some very nice descriptions, and the most recent one by Pierce et al. In the Journal of Orthopedic Surgery and Trauma is well worth reviewing. Considerations include the entry point, correcting any valgus deformity, using an intermedullary nail with some sort of locking of the neck to prevent a proximal hip fracture. But critically, there's a need to early mobilize on the fracture side. And this is important so we offload the non-fracture side, because it's the side that's at risk. There is a significant revision rate and the healing is slow, and this needs to be discussed with the patients to manage their expectations. What about the other leg? And this is where the FLS and the bone clinic really comes into its importance. It's very important that the contralateral femur is x-rayed in its entirety. So here's a patient who's had an atypical femoral fracture of the left femur, and we can see a femoral x-ray is done, but it's too short, and it has missed lesions distal to the first film. And when we assess these lesions, we want to know if it is a bump or if there's a fracture line, or what we call a beak. And beaks are more dangerous than bumps. The other learning is that MRI scanning is useful, but we really need to now use CT scanning as well, because we don't always see edema associated with atypical femoral fractures. So in this MRI, it looks pretty quiet. There's no real concern about any bone marrow edema, but on the CT, we can see there's a bump, and the bump is associated with a fracture line, so it's become a beak. The other role of the FLS is actually to make sure the patients stop anti-osteoporosis treatment. And here we can see that the risk of a contralateral atypical femoral fracture is actually very high. Over 1 in 4 went on to have a contralateral atypical fracture if they continued their anti-osteoporosis medication, compared with 4% who stopped. It's also important to know that stopping the treatment is problematic, because often these patients will have osteoporotic fracture. Up to half will have an osteoporotic fracture within the next 10 to 15 years. In terms of medical therapy, while there was initial enthusiasm to use teriparatide, actually in some preliminary work that's been presented at the American Society of Bone Mineral Research, it hasn't led to a difference in radiographic healing, and there were actually new incomplete fractures in patients who are on teriparatide. Also importantly, it's unclear what to continue with after teriparatide and how safe it is transitioning to an anti-resorptive. So what about the other anti-osteoporosis medications? Denosumab has been associated with atypical fractures, and this is both in people with previous bisphosphonate use and without bisphosphonate use. And romosozumab, in the trials there were a few atypical fractures, but all of these patients had had previous bisphosphonates. There's no current major signal for an association with atypical fractures with raloxifene, menopausal hormone therapy, or strontium, and these 3 drugs remain as options for patients who have moderate osteoporosis. So the real decision is whether to fix or not fix the contralateral femur when a patient comes to an FLS with an atypical fracture. Obviously, the benefit of no fixation is that you avoid further surgery and rehabilitation, but the risk is that you are then denying patients access to very potent anti-osteoporosis medication. And if they have untreated osteoporosis, as defined by either a very low bone density or a fragility fracture history or a high fracture risk assessment score, you may be opening people up having further fragility fractures. Also, there is still a contralateral risk of fracture in the first year, even if you stop anti-osteoporosis medication, so there is a risk of an emergent complete fracture on the other side. And often we ask our patients that if they get thigh pain, they must be imaged, and this can lead to anxiety in the patients when any flicker of thigh pain leads them to be very sensitized that they may be having an atypical fracture. The benefit of fixing a contralateral femur is that then you're then free to use any anti-osteoporosis medication, even very potent anti-resorptives, without fear of an atypical fracture. The main risk is that you're now fixing an effectively normal femur. So the patient comes into the clinic with a painless leg, and then you do a femoral nail, and they leave with a painful leg that needs substantial rehabilitation that may take many months. and this can sometimes be difficult for patients. And in some very elderly patients who maybe have limited life expectancy, it is a discussion of how much of their remaining life they want to spend in rehabilitation versus being protected against fracture. How do we actually make this work in the clinic? So the steps we do is to understand what is the risk of ongoing fragility fractures, where we DEXA or do vertebral fracture assessment. We rule out secondary causes and optimize calcium vitamin D. It's often worth getting a trauma surgeon or anesthetic opinion on the risk of a fixation of the other femur, so the patient can weigh them up, and then really discuss with the patient what their values are in terms of how much of their remaining life do they want to spend in rehabilitation versus being at higher fracture risk. And do remember, the older you are, the higher the surgical risk and rehabilitation burden. So what happened with this patient? Well, she actually had intramedullary nailing of the broken leg and had quite a slow recovery, which isn't unusual. She declined contralateral surgery and we tried strontium. She then, however, developed cognitive decline, which probably wasn't related to the strontium, and over the next 10 years had 4 episodes of severe vertebral fractures that required more opiates and actually worsened her dementia. Unfortunately, by this time, she was too unwell for contralateral surgery, and we basically managed her with analgesia when she had a vertebral fracture, and she passed away some 10 years later of COVID. So I hope I've been able to open up the discussion that often as NFLS team we have to make the balance between the treatment unwanted and the benefit from fracture reduction with our therapies. So we talked about atypical fractures, which is a rare side effect. What about a more common risk? So here's a 82-year-old woman who's had a recent humeral fracture. She had a DEXA and a VFA. The VFA showed 3 previous vertebral fractures. The femoral neck T-score is -3.8, and her creatinine clearance, because she's over 82, we don't use EGFR, was only 20 mils per minute. Now, if the renal function wasn't low and there wasn't a previous history of MI, you may be thinking of anabolic therapy. You may even be thinking of the romosozumab, but in the presence of a previous MI, this makes romosozumab not appropriate, and with this level of creatinine clearance, then actually even PTH analogues are of uncertain benefit. So the really only agent you can be thinking of is denosumab, because the use of bisphosphonates may further worsen her renal function. So this is actually a very common scenario because kidney disease is getting more common. As people are getting older, more people are getting kidney disease either due to diabetes or hypertension or other causes, and you can see it's very age related. And we know that having kidney disease is a significant risk factor for further fractures. So here you can see the increased risk of hip fracture even after you adjust for age in people with an EGFR of less than 45, which isn't that low in our clinic actually, compared to people with EGFRs above 45 or above 6. And this also applies to spine fractures as well as to hip fractures. And we know that if patients do have a hip fracture and have chronic kidney disease, they do far worse. So in this analysis of the US renal data system looking at dialysis patients, having a hip fracture doubled your risk of death compared to patients who weren't on dialysis. So avoiding a hip fracture in a patient with chronic kidney disease is very important, because over half of them will be dead by 1 year. So how do we do that? Well, it's actually very complicated, because here I've listed the drugs from the oral bisphosphonates, intravenous bisphosphonates, denosumab, PTH analogues and romosozumab, and you can see there's a caution or a contraindication for most of them. And it works in 2 ways. One is that some of these agents may worsen renal failure, and there's evidence of this for both oral and intravenous bisphosphonates, but maybe not so much with abandronate. But also that you may get quite significant side effects, and the main side effect is hypocalcemia. So we know that with denosumab there is an increased risk of hypocalcemia, and this can be extremely serious. And this is a study where patients on dialysis were actually given denosumab, and they were given denosumab in the setting of quite standard therapies that would reduce the risk of hypocalcemia. So they were all on activated vitamin D. Whether that was enough, we're not sure. And you can see even with careful management of their bone metabolism, you still had one patient who had a very severe hypocalcemia requiring urgent intervention. So often as doctors we're left with this challenge of we have patients at high or very high risk by their recent fracture, previous fracture history and bone density results, and yet we also have the adjacent risk of severe hypocalcemia. So well, what can we do to reduce the risk of hypocalcemia in the fragility fracture setting? Well, there are many things that we can contemplate that help reduce the risk of hypocalcemia with denosumab. So this very nice review that I was very fortunate to be invited to contribute and led by Dr. Evenpoel from the nephrology side has actually laid out a pragmatic approach to managing osteoporosis diagnosis and also management in the setting of CKD 4 all the way down to dialysis. And one very common question we come to is, do we need a bone biopsy? And there are now much clearer recommendations of when it would be reasonable to perform a bone biopsy. So if there's unexplained fractures, persistent bone pain, if there's abnormalities that are not explainable, such as hypocalcemia and hypophosphatemia, or aluminium toxicity. Importantly, it's not mandated to have a bone biopsy prior to anti-osteoporosis medication. And a very important question is, what is the value of finding or diagnosing adynamic bone disease? In the past, adynamic bone disease was mainly due to aluminium causing the adynamic bone phenotype, but now it's due to a different mechanism, and we're not quite sure of its clinical relevance in terms of making therapeutic decisions. The other aspect of bone biopsies is what sort of biopsy do you want, and that depends on the question. Double labeling is the gold standard, but it's complex to analyze. There are very few centers that do this. It takes lots of time, cost and expertise. And actually it depends on the question, and if you want to just rule out osteomalacia or high or low bone turnover, this can be done with just standard histology. So I'm just going to walk through an approach to assessing hypercalcemia risk in patients with severe kidney disease that you can think about instituting in your FLS patient who presents with very high or high fracture risk. So the first question is the renal function stable? Clearly, if the creatinine is very unstable and is generally worsening, then it's probably not worth initiating denosumab, because the duration of treatment will be short as the kidney function becomes very low. It's very important to ensure the vitamin D level is replete and that any signs of osteomalacia are adequately treated, both in terms of calcium and vitamin D repletion. It's critical to understand the PTH axis. Is there evidence of hyperparathyroidism? Is this secondary? And it's important to know that if you do have patients with raised PTH with a normal calcium, this may actually indicate insensitivity of PTH and a concern that if the patient does develop hypercalcemia, the PTH resistance or insensitivity may lead to a lack of a normal homeostatic response and further drops in calcium. We talked a little bit about adynamic bone disease, so you'd look at the alkaline phosphatase, the PTH, and if necessary perform a bone biopsy. As bone doctors, we don't often measure the bicarbonate, but it's useful to check the bicarbonate to make sure there's no acidosis, because that can be readily corrected with some bicarbonate. I've already mentioned the importance of not forgetting the other aspects, so it's worthwhile checking the calcium intake, but also other lifestyle factors such as alcohol and smoking. And then finally, the management of patients on denosumab is quite intensive, so you need to make sure that primary care or the healthcare system is accepting taking on the extra monitoring. And then finally, you need to make sure the patient is happy, because at the end of the day, it's the patient's decision whether to reduce the fracture risk with denosumab and accept the increased risk of hypocalcemia, which can be very severe and life-threatening in certain cases, or to not expose themselves to denosumab and continue at very high risk without any treatment to reduce that. So I hope I've been able to give you an overview of what an FLS is, and that for most of patients it's really a straightforward process of identifying them with a fragility fracture. They're over the age of 50, doing some basic history and some basic laboratory tests, assessing their fracture risk using fracture risk scores or DEXA, and then deciding on treatment. And then we spent a bit of time talking about the two common scenarios that can make the FLS patient more complex. And these were atypical femoral fractures and fracture in patients with chronic kidney disease stage 4. I work as a small cog in a huge team at Oxford. I really want to thank the FLS experts I work with around the world, the FLS team in Oxford, as well as at the Royal College of Physicians, and then finally the rare disease team I work with. It's a real privilege for me to present for you at CBOM because I worked very closely with mentors, and I just want to acknowledge all the enthusiasm and support that Bernardo Stolnicki gave me. He was an incredibly generous mentor and friend, and I had the privilege to meet him, and he hosted me in Brazil on a couple of occasions, and was always very generous with his time and his insights into how orthopedics in particular should really lead the way for fracture liaison services. So I want to thank you, Bernardo, for all your support and really want to commend you on the legacy you've left for the country and also for the region. So thank you very much. I hope you've taken away some useful pointers for what is an FLS, some tips for managing patients who come to the FLS with atypical fractures, as well as those patients who come in with chronic kidney disease stage 4, and rather than just consider them ineligible for anti-osteoporosis treatment, maybe have a more structured approach for understanding which of those patients who are at very high fracture risk actually can be managed with anti-resorptive therapy in a safe and effective way. Thank you very much.